As you know, is hormone receptor positive HER2 negative early breast cancer. It's a very heterogeneous group, and the equation of optimal prognostic markers in these patients appears to be very important. And to be used today, genomic assays, for example, Oncotype DX, we use clinical risk, and there is some uncertainty which markers have to be additionally used in this setting to have more precise definition of the relapse risk in these patients with, in particular in those with up to 3 positive lymph nodes. And we have done a large ADAPT study in Germany. First survival data from the study were presented a couple of years ago and published in the meantime in the Journal of Clinical Oncology. In this study, we combined for the first time genomic assay, Oncotype DX, and response to endocrine treatment, to short-term endocrine treatment given for 2 to 4 weeks before the surgery, and Ki-67 response to the endocrine treatment. We combine both assays together with clinical risk in patients with intermediate to high risk disease, to build two groups, to build the group with endocrine treatment alone and to give treatment with chemotherapy. And as you know now, for the group with low risk, with recurrence score of 25 and response to endocrine treatment, we have shown excellent survival data in patients without chemotherapy, irrespective of their menopausal status. So this is a big difference to the results from the TELRIX trial and the Responder trial performed in the US and the MINDAC trial in Europe. But the big question will remain: who are the patients in the high-risk group who really need chemotherapy, or is there some patients who do not chemotherapy? So this is a major question in the hormone receptor positive HER2 negative disease. And now we have performed some complicated kind of multivariable analysis to build different prognostic groups in the patients with endocrine treatment alone and patients treated by chemotherapy. And we have shown that in particular in patients with high-risk disease, all treated by chemotherapy in our study, but in this group we are able to have very different risk situations based on the nodal stage, tumor stage, genomic assay, for example, Oncotype DX, expression of progesterone receptor on the immunohistochemical level, and for the first time also the histology. And this analysis is presented for the first time, from the large prospective trial.